Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 143 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, SLP, a 69-year-old female patient is rushed to your accident and emergency department from a long-term care institution. She has a urethral catheter fixed while awaiting admission. She is admitted to your MICU following a diagnosis of respiratory failure as a result of very severe pneumonia. The intensivist initiates SLP on levofloxacin and vancomycin. On MICU day 6, she develops a new fever with a temperature of 38.9 degrees Celsius, an elevated WBC to 18 × 10⁻³ cells per millimeter cubed, despite an initial clinical response to pneumonia therapy. Blood and urine cultures are sent and urinalysis shows many bacteria, more than 10 white blood cells per millimeter cubed. So my question to you is, which of the following would be the next best course of action in SLP's clinical scenario? Would it be A. Insert a new or fresh urinary catheter and resend a urinalysis to confirm CAUTI, or B. Initiate empiric antibiotic therapy for a suspected catheter-associated urinary tract infection CAUTI, or C. Continue healthcare-associated pneumonia HCAP therapy for an extended treatment duration, or would it be D. Await final culture results before changing the current antibiotic regimen? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Initiate empiric antibiotic therapy for a suspected catheter-associated urinary tract infection, CAUTI. The presence of new fever and an elevated WBC in conjunction with an indwelling urinary catheter and pyuria on urinalysis is highly suggestive of a CAUTI rather than worsening HCAP. That makes answer C incorrect. Similar to other ICU-related infections, empiric antibiotic therapy should be considered if there is strong clinical suspicion for infection. That makes answer B correct. Waiting for the final culture results before initiating antimicrobial therapy in patients thought to have a CAUTI may delay appropriate treatment. That makes answer D incorrect. Although it is recommended to discontinue the urinary catheter and replace as necessary, a confirmatory urinalysis is not needed if the catheter has been indwelling for less than 2 weeks. That makes answer A incorrect. Let's move to the next question, please. And the next question reads, considering SLP's risk factors for multi-drug-resistant pathogens, which of the pathogens listed below would most likely be associated with a CAUTI in SLP's clinical scenario? Would it be A. Pseudomonas aeruginosa, Enterococcus species, and MRSA, or B. MRSA, Enterococcus species, and Candida albicans, or C. Enterococcus species, Candida albicans, and S. multifila, or would it be D. Escherichia coli, Pseudomonas aeruginosa, and Candida albicans? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Escherichia coli, Pseudomonas aeruginosa, and Candida albicans. The causative pathogens associated with a CAUTI, with or without multi-drug-resistant risk factors, are more heterogeneous than an uncomplicated or community-acquired urinary tract infection. Nonetheless, Escherichia coli remains the most common bacterial pathogen together with other gram-negative bacilli and Candida species. That makes answer D correct. Except for S. multifila, answer C is incorrect. Other associated pathogens include those Escherichia coli listed in answers A, B and C. However, the absence of Escherichia coli makes these answers incorrect. Let's move to the next question please. And the next question reads, JRI, a 66-year-old female patient is rushed to your accident and emergency department with a chief complaint of severe acute abdominal pain located in the left lower quadrant. She is admitted to your SICU and abdominal CT is done and it shows free air in the peritoneal cavity and evidence of distal ischemic colitis. JRI is emergently rushed to the operation room. Gross contamination from distal colonic perforation with marked peritonitis is noted. Partial colectomy and abdominal washout are done. JRI is admitted to the SICU for continued resuscitation for septic shock. So my question to you is, which of the empiric antibiotic regimens listed below would be the most appropriate for JRI post-operatively? Would it be A. Piperacillin, tazobactam, or B. ertapenem, or C. ciprofloxacin and metronidazole, or would it be D. ceftriaxone and vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Piperacillin, tazobactam. This patient has complicated intra-abdominal infection from secondary peritonitis caused by colonic perforation. Although it is community-acquired, the presence of septic shock suggests severe classification increasing the risk of gram-negative MDROs. That makes answer B incorrect. The involvement of the colon also obligates antibiotic therapy active against anaerobes and enterococci. That makes answer C incorrect. MRSA is an unlikely pathogen. That makes answer D incorrect. According to this, piperacillin, tazobactam is the most appropriate agent listed. That makes answer A correct. Let's move to the next question please. And the next question reads, A-OK, a 55-year-old male patient is admitted to your SICU with a past medical history significant for severe peripheral vascular disease. He has a chief complaint of severe acute abdominal pain located in the left lower quadrant. An emergency abdominal CT is done and it shows free air in the peritoneal cavity and evidence of distal small bowel ischemia. A-OK emergently undergoes exploratory laparotomy. He has gross peritoneal contamination with marked peritonitis from a small bowel perforation. Intraoperative cultures were sent and are pending. After primary repair of the distal small bowel and abdominal washout, AOK is readmitted to the SICU for continued resuscitation for septic shock. So my question to you is, which of the empiric antibiotic regimens listed below would be most appropriate for AOK's clinical scenario? Would it be A. Cefazolin plus metronidazole plus fluconazole, or B. Vancomycin plus ciprofloxacin, or C. ertapenem, or would it be D. piperacillin, tazobactam? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. piperacillin, tazobactam. The approach to managing a complicated intra-abdominal infection includes timely source control and initiation of empiric antimicrobial therapy active against likely pathogens. This involves assessment of the anatomic location of the source, risk factors for multi-drug resistant organisms, i.e., community or healthcare-associated disposition, and severity of illness. This patient has community-acquired secondary peritonitis from a distal small bowel perforation with concomitant septic shock. Although his disease is community-acquired, the presence of septic shock suggests a severe classification, increasing the risk of gram-negative multidrug-resistant organisms, and involvement of the distal small bowel obligates empiric coverage for anaerobic pathogens and enterococci, for all of which piperacillin, tazobactam should provide appropriate empiric coverage. That makes answer D correct. Ertapenem would likely have adequate empiric coverage for enteric, gram-negative pathogens, both aerobic and anaerobic. However, lack of enterococcal coverage makes it less optimal. That makes answer C incorrect. Ciprofloxacin lacks sufficient activity against enterococci or anaerobic pathogens, and MRSA coverage with vancomycin is unnecessary. That makes answer B incorrect. Cefazolin is too narrow as empiric therapy for a severe community-acquired complicated intra-abdominal infection, and fluconazole should be reserved for definitive therapy for fluconazole-susceptible yeast identified on final culture. That makes answer A incorrect. And the next question reads, HMC, a 45-year-old male patient presents to your accident and emergency department with a chief complaint of acute, severe epigastric abdominal pain. He has a past medical history significant for chronic alcohol abuse. His vitals include a heart rate of 142 beats per minute, an MAP of 62, a WBC of 24 × 10⁻³ cells per millimeter cubed, and a serum lipase of 1527 units per liter. HMC is resuscitated with 3 liters of normal saline IV over 1 hour. An abdominal CT scan is done and is remarkable for significant pancreatic edema and greater than 30% necrosis of the pancreas. There is lack of evidence of fluid collection. So my question to you is, which of the regimens listed below would be the most appropriate for HMC? Would it be A. None, since prophylactic antibiotic therapy isn't indicated in acute pancreatitis, or B. Meropenem, or C. ciprofloxacin plus metronidazole, or would it be D. vancomycin plus ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. None, since prophylactic antibiotic therapy isn't indicated in acute pancreatitis. Acute necrotizing pancreatitis often presents with signs and symptoms consistent with systemic inflammatory response syndrome. However, most cases of severe necrotizing pancreatitis are sterile and do not require antibiotic therapy. The presence of a pancreatic pseudocyst or abscess increases the likelihood of infected necrotizing pancreatitis, which thus warrants empiric antimicrobial therapy. However, this patient has no evidence of these on CT scan, thus empiric antibiotic therapy isn't indicated. That makes answers B, C and D incorrect. Moreover, prophylactic antimicrobial therapy is not recommended in the recent guidelines, despite the presentation of systemic inflammatory and pancreatic necrosis. That makes answer A correct. A prospective, randomized, non-inferiority study most strongly supports these recommendations. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 144.